Hello guys, welcome to our channel. Today we will be discussing of the most important topics of the psychiatry. In this we will be covering of the few basic PYTs and also essential topics that we can expect in the upcoming examination. So basically the psychiatry will be consisting of the 4 to 5 questions, but that questions are going to play the major role, right? So let's start the discussion. Those who are new to this channel, please do subscribe and share with your friends. And also if you want to avail the notes, please do join the Telegram group and text me from there. So let's start the discussion, guys. So here you can see this is one of the most contributed neurosurgeon. He is not a psychiatrist, but his contributions to the psychiatry and the psychology is one of the most appreciated things in the history of the psychiatry. He is none other than Freud. So you all might have known the Freud theories and his discoveries, the different types of the human psychology has been one of the greatest contributions to the psychiatric evolution. So let's start the discussion, guys. So first and foremost important points about the schizophrenia. We will be starting with the schizophrenia. So before, if you want to know about the schizophrenia, we have to differentiate that the psychiatry is subdivided into the two types. One is the psychosis. So the patient will be having the psychosis, and the patient, some of them will be having the neurosis. So there is a theory between the psychosis and the neurosis. So psychosis, so the patient will be having the disturbance. Okay, so the patient will be having the significant disturbance quality of the life, whereas neurosis patients is not significantly the patients are affected by this experience. So this is the one of the common differences. And also reality, so the patient reality is disturbed. So here no reality is disturbed in this patient, whereas judgment, okay, judgment and also insight, everything is disturbed in the patients of the psychosis, whereas in the neurosis patients it is not disturbed. So what are the examples of the psychosis? Schizophrenia. What are the neurosis examples? For example, generalized anxiety disorder. These are the some of the examples. Next, coming to the discussion of the delusions and also the other points that you have to take note about the hallucinations. So first we will be discussing of the delusions. Okay, so delusion, what is mean by the delusion, guys? So delusion is a false fixed belief. Okay, so the patient is suffering from the false fixed belief. So among them, what is the most common type? The most common type will be seen as a prosecutory type. Okay, this is prosecutory type. Again, this is seen in the most of the time schizophrenia or the substance abuse patients, but they are some of the syndromes that you have to remember. So these syndromes can be asked in the potential MCQs for the examination. Let's see. First we have the Otello syndrome. So Otello syndrome is morbid jealousy. So the patient is having the jealousy on what? So for example, let's say the patient is alcoholic patient. So he will be having the jealousy on the wife. So he will be thinking that his wife is doing cheating on him. So this kind of syndrome is the Otello syndrome. Next, we also have the erotomania. We also have the erotomania. For example, some of the cinema actor, we feel that that person is loving us, that's why he is making that movie. So this is like a delusion of the love from others. Okay, delusion of the love from others. So this is also known as a de Clermont syndrome. Next, we also have the Cotard syndrome. So Cotard syndrome is about the depression. So this is associated with the patient with the depression, and also he will be thinking of the negative mindset. So the patient will be having the negative mindset, or we can also say nihilistic mindset that the patient will be suffering. Next, we also have the Magnon syndrome and egg bomb syndrome. Okay, Magnon syndrome and the egg bomb syndrome. So Magnon syndrome, the patient will be having history of drug abuse. Here no drug abuse, right? Next, what is a Magnon syndrome? So Magnon syndrome is the patient is thinking of the formification. What is mean by the formification? So the patient having the tactile hallucinations with some bugs are crawling inside his or under his skin. So that is what the patient will be thinking with the history of drug. So the most common drug is the cocaine, right? Next, the patient with the egg bomb syndrome, he is having the restlessness. So he will be thinking some of the parasitosis, he is making him to sleeplessness and also the restlessness without any history of the drug. So sometimes they will be bringing of the packets, matchboxes, so they will tell these are the bugs that is crawling on me. So this is not the egg bomb syndrome. Next, we also have the Capgras syndrome and Fregoli syndrome. So remember, Fregoli is like a friend. Even though he is a friend, he is a stranger, okay? And that stranger will look like a close person, okay? That stranger will look like a close person. Next, Capgras. Capgras is known person, but you will think he is a stranger. He is a stranger. So this is known as a dilution of the misidentification that is seen in these patients. So these syndromes that can be asked as a potential questions. Next, moving on to the hallucinations. So we have so many types of the hallucinations. So what is mean by the hallucination? It is a false perception. So the patient is having the false perception. So the most common is the auditory, okay, followed by the visual and also tactile and gustatory. Okay, so auditory is generally seen in the patients of the schizophrenia. Visual is seen in the patients of the drug abuse. Same as the tactile is also seen with the history of the drug abuse. Gustatory is seen in the epilepsy patients. Okay, gustatory is seen in the patients of the epilepsy patients. Next, we also have the true hallucination and the pseudo hallucinations. Let's say true. Most of the times you feel, okay, that is obviously that is a wrong thing. What we think whenever our parents tell something good for us, we'll think, oh, the parents are telling wrong, everything wrong. They are looking into the wrong eyes. But outside people, very good people. So let's imagine a youngster is thinking that the outside, so the outer space is true, okay? So this is known as a objective type of hallucination, whereas pseudo is inner. It is a subjective hallucination. It is a subjective hallucination. So this is how we have to remember delusions and also the hallucinations. Next, coming back to the schizophrenia, first, who is the person that has termed the schizophrenia? So this schizophrenia is the word is came from the Buller. Okay, so the scientist is the Buller who has coined the term of the schizophrenia. Before that, it used to known as a dementia precox or the chronic cognitive disturbances. So these are the some of the names that is given. So Buller is the one who has coined the schizophrenia, and he has given the 4 years. So what are these important 4 years that you have to remember? First, it is autism, and second is ambivalence, and the patient affect, flatten, and association loss. Okay, association loss. These 4 A's were given by the Bueller, and he has tell the if this is present, the patient is suffering from the schizophrenia. And after the discovery, there is another scientist has came. His name is Kurt. So Kurt has given the 11 symptoms. Okay, 11 symptoms, and he said these are the first rank symptoms to diagnose. So what are these for 11 symptoms, guys? Basically, there will be three auditory hallucinations. For example, first person, second person, third person, different hallucinations will be seen. And three made phenomena like impulse, violation, effect. And three thought phenomena is present, and along with that there is a somatic passivity, and also the patient will be having the delusion experience. Okay, delusional experience. So these are the 11 symptoms that Kurt has given to diagnosis. Over the time there is many discoveries has came, and the finally we have stick to the DSM-5 criteria. DSM-5 criteria. So DSM-5 criteria will tell us if there is a patient with a 6 months history of following symptoms. If ever the patient is present, then we have to consider this patient is suffering from the schizophrenia. So what are the symptoms? Let's see. So the patient is having the delusion, or patient is having the hallucinations, or patient is having the disorganized behavior. So any one has to be presented from these three, and patient is having the negative symptoms such as apathy, avolition, and also patient is having alogia. All these symptoms, if it is presented, those are the negative symptoms. So the patient, if ever is more than 6 months with any of this, two at least two symptoms is present, then we can consider this as a schizophrenia patient. Because why we have to take note of about this? Because if you don't take note about this, there is the other criteria is also presented. For example, let's see. For example, the patient is having the delusional syndrome. So this name itself tell us that it is a delusional syndrome which is only present with a delusion. No other symptoms will be presented in these patients, right? That is a one form. Next, we also have the brief psychotic syndrome. Brief psychotic syndrome. This brief psychotic syndrome is less than 1 month only. This is less than 1 month. Next, schizophrenia form. Schizophrenia form. Schizophrenia form is 1 to 6 months. Schizophrenia form is 1 to 6 months of the condition. And next, delusional syndrome is less than 3 months. Less than 3 months. So this is how there are the different timelines. Only the disease that is present with the these 6 months criteria, that is a schizophrenia. In the schizophrenia, we also have the types. So the types coming to here, the most common is the paranoid type, and this paranoid type is having the good prognosis. Okay, good prognosis. And the second most common is the catatonic type. This is also having the good prognosis type. But third one, this is the Haber form, Haber-Pfennig, Haber-Pfennig form, and this is having the worst prognosis. Okay, this will be having the relapses and also worst prognosis will be seen. And where this positive symptoms is coming. Okay, these are the positive symptoms, and I said this is the negative symptoms. So the positive symptoms, which is delusions, hallucinations, is coming from the mesolimbic pathway. In the brain, it is activated with the help of mesolimbic pathway D2 receptors. Okay, high D2 receptors. Negative symptoms, which is coming from the mesocortical pathway. These are coming from the mesocortical pathway. And this is with the D2 and opposing action with 5-HTA. Both are increased here. That is due to mesocortical pathway, right? These are the two symptoms that you have to remember. Next, we have to differentiate for this as whichever is going to be the good prognosis, whichever is having the bad prognosis. So we have to find out those. So if whoever is watching this video, if anyone have watched a beautiful film, A Beautiful Mind, this is about the mathematician. He is a Nobel Prize winner of the USA. That movie will tell us what is a good prognosis and the bad prognosis. I will tell you. So the patient in the movie is a male and he is a young. Okay, he has a history of the family with the schizophrenia from his mother's side. All right, and he is having the birth trauma, and he is occupied by the quality of life, good life. Okay, good life, he is having this. And in usually these patients will be having sudden, in the good quality of life, it will be insidious, the presentation will be seen with these patients. So all this will be likely to be the bad prognosis. So the hero is the main protagonist in the Beautiful Mind. He is the male young mathematician who is going with a good life. He suddenly got these symptoms. He has a history of the schizophrenia with birth trauma. All this will be concise to the worst prognosis. But coming back to the good prognosis, mostly this is the female patients, and the patient's age is very late ages and acute incidents, and also patient is having the more of the positive symptoms than the negative symptoms. The patient is having the mood syndrome. Okay, mood disorders in the family history but no schizophrenia infection, and all this will be concise to the better prognosis. So this is about the prognosis of the patient. So okay, you can just remember with the mnemonic of that movie, the A Beautiful Mind. After your exam you can watch. This is one of the best film also, I would recommend for you guys. Next, moving on to the another important point. Whenever we see this schizophrenia, This is just a basic thing only. The main thing that comes here is the antipsychotics. Okay, that is antipsychotics, which is frequently tested in the examination. So we have two generation. We have first generation drugs and we also have the second generation drugs. So the first generation drugs are the typical antipsychotics. These are the atypical antipsychotics. Now we also have the third generation, but most commonly CDC approved is the first generation and the second generation drugs. So what is the mechanism for the first generation drugs? So these first generation drugs, they are going to block the D2 receptors. Second generation blockers is also going to block the D2. Along with that, 5-HT is also going to be blocked here. So these two, whenever the serotonin and the D2 is blocked, that is a second generation. In the first generation, it is only first the D2 is blocked. So this will relieve the patient from the positive symptoms. Okay, so this will be relieved of the positive symptoms in the patient. And second atypical drugs, this will be negative symptoms which will be relieved by the second generation drug, but the toxicity which will be associated is more with the first generation. Okay, toxicity is more with the first generation, especially extrapyramidal symptoms, that is due to extrapyramidal symptoms, whereas second generation drugs, this is also having the equal toxicity, but this toxicity is mostly seen with the metabolic symptoms. This will be seen with the metabolic symptoms. Next, coming to the drugs and examples. Here you can remember the most common one, that is the haloperidol. The patient is given with the haloperidol. This is the one of the drug that is seen, and also chlorpromazine. Okay, chlorpromazine. This is also drug. Next, second generation clozapine. Second generation is clozapine, olanzapine, and risperidone. Okay, risperidone. So these are the drugs, that is first generation and the second generation. Then what is this? The side effects of the extrapyramidal symptoms. Let's see. Extrapyramidal symptoms, which is the most common, is every patient may suffer, that is acute dystonia. So within hours of starting this drug, what does it drugs will do? It is going to activate the sympathetic system of the body, and this will going to cause the patient with a crisis. So the patient will be having the muscle spasms, okay, muscle spasms, trismus, oculogyric reflexes, all this will be presented in this patient. Next, second one is the akathisia. Okay, akathisia is nothing but restlessness. So the patient is not going to sit, and patient will be severely restlessness that is presented. It could be acute or it could be chronic. So but these symptoms will be presented within the days of the starting drugs. Next, third drugs. Third class of the drugs, which so third symptom is Parkinsonism, drug induced Parkinsonism. So the patient will be having the tremors and also other cognitive disturbances will be seen in this patient, right? Tremors is most common symptoms. Next, fourth one is the tardive dyskinesia. Okay, fourth one is the tardive dyskinesia. Tardive dyskinesia is also presented over the days, or we can say years. Most of the times the patient will be having the perioral tremors. Okay, perioral tremors and also metabolic disturbances will be seen in this patient. Next, fifth one is the malignant neuroleptic hyperthermia. So malignant hyperthermia, which is associated with the drugs, the patient will be having the increased heart rate, increased BP, increased temperature, right? These are the symptoms. Then how we are going to treat? Because we have to treat these patients, right? So for the patients of the acute dystonia, you can give the benzexol. Okay, you can give benzexol for this patient. And the patients with the akathisia, restlessness, here you can give the patients with the beta blockers. Propranolol can be given for this patient. Parkinsonism patients, for this patient you can give the benzatropine. Okay, benzatropine can be given for this patient. And tardive dyskinesia and the malignant hyperthermia, for these patients you have to stop the ongoing drug. Okay, first thing, you have to stop the ongoing drug, then shift the patient to atypical. Okay, atypical drug has to be shifted on the low doses. And the other drug that you can give is the valbenazine. Okay, so you can also give the patient valbenazine. That drug can be also given for this patient. And malignant hyperthermia patient, we are going to follow A, B, C. Amantadine, okay, amantadine, and also bromocryptine, and cause agent has to be removed, and dantrolene. The best drug is the dantrolene, but you have to remove the underlying cause, and bromocryptine and amantadine is also given to stabilize the patient, right? These are the symptoms that you have to remember. Next, we also have the other metabolic symptoms, right? So I will be explaining the metabolic symptoms also. 1 minute. Next, some of the other symptoms the patient might be having, you can write this is different from the above symptoms, guys. Basically, the patient will be having the hyperprolactinemia, right? Increased prolactin levels, which will be causing this patient's hyperprolactinemia. So you have to remember which drugs are most commonly associated. So the most commonly associated drug is the risperidone and olanzapine. Risperidone and the olanzapine. And clozapine have multiple symptoms. Clozapine will be presented with the sialorrhea. So the patient will be having the sialorrhea, that is one of the common symptoms, and patient can have the agranulocytosis, neutropenia is seen in this patient, and also seizures. Okay, seizures, and in severe cases the patient can also have the myocarditis. Okay, myocarditis also seen in these patients. That is the one thing the clozapine is associated. Next, quetiapine. Okay, quetiapine can cause the cataract. Quetiapine can cause the cataract, and olanzapine is having the less metabolic symptoms. Next, another important point that you have to remember is that which of the drugs is going to have the zero incidence. Okay, zero metabolic side effects, that is Z for zero, Z for ziprosidone. Okay, ziprosidone, but ziprosidone is having the QT prolongation. If ever cardiotoxicity, that can be QT prolongation that we are going to see. That is a one point that you have to remember. So these are the some of the side effects that you have to remember, guys, for the different types of the drugs, right? Next, coming back to, so how we are going to give this patient. So the treatment for this patient is start with the typical drugs only first, then we'll move on to the atypical drugs. So if ever the patient is started with the typical drugs, that is low dose, okay, for 2 years. If there is a relapse, then we can go for the 5 years. Next, for the patients who is suffering from the resistant, then we can go for the clozapine. If ever the patient is pregnant also, we can go for the clozapine. If ever the patient is having the suicide also, we can go for the clozapine. So clozapine is ultimately the last choice that we can give for this patient. That is the first thing that you have to remember. Next, moving on to the mood disorders, that is a depression. So in the depressions, you have to remember they are the multiple types, right? We have the depression and euthymia and cyclothymia and mania. All this will be presented here. Let's see one by one as per the definition. And if you see the patient is suffering from the any of the five symptoms for more than 2 weeks, like sleep disturbances, interest is not properly came, guilt, energy is deficient, concentration is disturbed, appetite, psychomotor activity, and suicidal ideation, this patient is suffering from the major depression disorder. Okay, so this is the major depression disorder. Remember, timeline is 2 weeks with 5 symptoms of the Psyche caps, right? Next, another symptoms is mania. So mania is nothing but it is going to be the high mood. High mood. So depression is the low mood and this is going to be the high mood. What are the symptoms? Distractibility, impulsivity, grandiosity, flight of ideas, activity is increased due to the weight loss and increased libido, sleep is decreased, and talkativeness. So this is known as a bipolar. And how many months bipolar? One. How many months or the weeks? This is only equal to 1 week. And we also have the bipolar 2. Bipolar 2. So all this will be present, but in the mild dosages. This is known as less than 4 days. Less than 4 days is a bipolar 2. Other name, this is mania, and other name here is the hypomania. Okay, this is the hypomania. Here, coming back to here, you can see the patients whoever is suffering from the low mood frequency, that is a hypomania. If ever the patient is suffering from the depression for the 4 weeks, that is a depression. And if the patient is elevated with a sudden mood, that is known as a hypomania. That is the one thing that you have to remember. Next, we also have the schizoaffective disorder. Schizoaffective disorder is presented with the psychosis. So the patient is suffering from the psychosis for more than or equal to 1 month with major depression disorder. This is the psychosis. And the specific thing that you have to remember for this patient is we are going to give the phototherapy. Remember the phototherapy that we give for the patients who suffer from that jaundice in the newborns, right? So for these patients also we can give the phototherapy as a treatment. Next, so there are so many other definitions also that you have to remember. For example, double depression. So what is mean by the double depression? Before that, you have to know about other definitions like dysthymia or cyclothymia. Dysthymia and cyclothymia. Dysthymia is more than equal to 2 years, so the patient is having the low mood, so that is a dysthymia. Or patient is having the more than 2 years with mania or hypomania. Okay, in the mild symptoms only, that is the dysthymia. So double depression is the patient is usually associated with the dysthymia, right? So that patient is already suffering from the dysthymia, suddenly he will be having the major depression disorder which is more than equal to 2 weeks. Okay, that is the double depression. Next, we also have the atypical depression. Okay, atypical depression. So in the atypical depression, for example, come back to the depression, the patient sleep is disturbed, patient appetite is disturbed. So in the atypical one, these both are increased, so the patient will be having the high hyperphagia and also hypersomnality. So these are the changes that you are going to see. This is known as a atypical depression that is seen in these patients. Next, another points that you have to remember here is the postpartum blues, postpartum psychosis, and postpartum depression. Okay, so after the delivery, whenever the patient is having after the delivery, within 4 days, within 1 week, and within 1 month or 1 year also, the patient can be presented with this condition. This is the postpartum blues, psychosis, and the postpartum depression. So here the mother will be crying. These are the important always having the cry and anxiety in this condition. Those okay, that is seen in the postpartum blues. In the psychosis, the mother is having the delusions or mother is having the hallucinations. Hallucination is seen. Depression phase, again digicaps, which is more than or equal to 2 weeks timeline. But which is more danger? So this is more danger because it can harm the baby or can harm herself. And here only suicide by her, but not to the baby. So the baby harm is seen with the only psychosis. So for this patient, for the blue patients, we can go for the supportive therapy. So no treatment is given because it will settle by itself. For this patient, you have to admit in the hospital. You have to admit in the hospital for this patient, and for this patient you can go for the SSRIs. Okay, SSRIs can be given for this patient. So that is the difference between the postpartum blues, psychosis, and the depression, and types of the different definitions that we have discussed. So in the depression also, another point, only the important topic that if ever is examiner is asked, that is going to be the antidepressants. And recent INCT question was, what is the novel drug of the depression? What is the novel drug of the depression that we are going to use for this patient? So the drug name that is recently added in, it is using by the many countries like Western countries. In the India, it is not yet using. The drug name is the vilazodone. Okay, vilazodone is known as a novel drug that is used for the depression patients. So we all know that depression is having the different types of the drugs, right? First and foremost, we have the SSRIs Okay, SSRIs will stop the SSRI inhibitors, right? Whenever the SSRI is taken, the serotonin is taken back, it is going to block that particular place. And these drugs is commonly are fluoxetine, paroxetine, and sertraline. So these are the SSRIs that we have. And SSRIs which will be having, this will be having the longer duration. This is having the longer duration. This is having the shorter duration. And which conditions we are going to give? We give for the major depression disorder as a first line, and I can use for the phobias also, and I can use for the generalized anxiety disorder, and patients who is suffering from the PTSD, this condition also I can use, and also OCD patients we can use this one, and bulimia patients we can use, and also post-mortem depression also we can use. But certainly is best used for the pregnancy people. In the pregnancy, fluoxetine or the paroxetine is contraindicated. What are the side effects? So side effects, it's going to have the dysfunction, sexual dysfunction like that is presented in this patient, and one of the side effects that we are going to see here. And next, other than that, important one is the serotonin syndrome. Okay, serotonin syndrome. This serotonin syndrome is same as here malignant syndrome. We are having the serotonin syndrome here. Serotonin syndrome, the patient will be having autonomic instability like increased BP or decreased BP, the patient will be presented, and clonus symptoms, and increased reflexes that is present in the serotonin syndrome. We have to stop the ongoing drug. And what is the drug of the choice given for this patient as a treatment? As a treatment, we can give the cyclopropeptide. This drug can be given for this patient to reverse that particularly serotonin syndrome. Next, coming to the another type of the drugs, that is SNRIs. Okay, this is the SSRIs, this is the SNRIs, and here it will increase the norepinephrine intake and also serotonin intake. So 5-HT is serotonin, guys. That is the intake is seen in these patients. And the examples is duloxetine. Okay, don't confuse here. Fluoxetine, paroxetine. So duloxetine is present in the SNRIs. That is the one thing that is a differentiate, and remaining all drugs you can identify. Next, SNRIs also having the same side effects like serotonin syndrome, but the major side effect that is present here is the hypertension crisis. So the patient can have the hypertension crisis that will be seen here. Next, tricyclic. The tricyclic antidepressants, these drugs will be having the major toxicity. Hypertension crisis will be seen with these drugs. So that is the hypertension crisis, especially the patient whoever is taking the thiramine rich food. For example, the patient is taking the cheese, okay, or the red meat. What happened? This will be causing the hypertension crisis that is seen with here. And for this toxicity, the drug of the choice, if ever I wanted to reverse this, so the drug of the choice is stop the drug. Okay, stop the drug, and then we can go for the bicarbonate. Okay, bicarbonate infusion is given for this patient. That is a tricyclic antidepressants that we are using, right? This is the one of the thing that you have to remember. Next, moving on to the one of the most important one, if ever the patient is having the resistant depression. So let's say the patient is having the resistant depression, what we can use for this patient? If ever the patient is having the resistance, then we can go for the ECT. We can go for the ECT, right? Electric convulsive therapy. And this electric convulsive therapy is given under the sedation. And for that, we are going to use the agent, that is barbiturate methoxytol. Okay, methoxytol. This drug is given. And for this patient, if ever the patient is going, the side effect will be headache. Most commonly the patient will be having the headache and retrograde amnesia. Immediately after the procedure, the patient might be having the amnesia. That is a retrograde amnesia that is going to be seen. And other drug, if you want to give, then you can give the osketamine. Okay, osketamine is the FDA approved drug also you can give for this patient. That is a resistant depression. And other than that, we can give the thyroxine, and folic acid, thyroxine, folic acid, valproate, and also lithium can be given for this patient. Next, coming back to that only, that is lithium. So why the lithium is given in the patients of the depression or the patient who is suffering from the bipolar disorders? What is the mechanism behind the lithium? So lithium is going to increase the mostly neurotransmitters, okay, neurotransmitters action. It is going to increase the neurotransmitters action by decreasing the IP3 and DAG, especially in the G proteins, the G protein coupled receptors. It is going to stop and increase the neurotransmitters, but it has very narrow therapeutic index. So it have therapeutic index around 1.0, sorry, 0.6 to 1.2 milliequivols per liter. So this is very have narrow therapeutic index. If ever you give more than 1.2, the patient can have the toxicity. What kind of the toxicity that we are going to see in this patient? So patient can present with the nausea, vomiting as a early, and patient can have the ataxia in the severe stages. Patient can have the nystagmus. Okay, centrally the patient is having and dysarthria. Dysarthria is seen. Patient can have the fine tremors, and if the toxicity increase, this can develop as a coarse tremors, and more commonly they can develop the diabetes insipidus. Okay, diabetes insipidus is seen due to nephrogenic cause, and other than that, hypothyroidism. Patient can have the hypothyroid, and if ever mother is taking, this can cause the abstinence anomaly. So ultimately, in the end of the stage, there is no antidote. You have to go for this patient to take the hemodialysis only. And the one question that is asked here, so here we are going to give for this patient, here we are going to give what is the drug to treat the diabetes insipidus. We are actually not going to give the thiazide. Actually, nephrogenic causes we are going to give the thiazide, but here we don't give because lithium concentration will increase. So lithium is directly proportional to NSAIDs, it is directly proportional to thiazides. So that's why we are not going to give the thiazides here. Rather than that, we are going to give the amiloride. Okay, amiloride is given as a drug of the choice of the patients for the diabetes insipidus with lithium toxicity. Okay, this is the depression and disorders, and also you have to remember this schizophrenia and the depression disorders and their treatment. That is the one point that you have to remember. Next, moving on to the anxiety disorders. Okay, moving on to the anxiety disorders. What are the anxiety disorders that you have to remember? The most commonly, the first and foremost, the most common anxiety disorder is the general anxiety disorder. So the patients who is suffering from the general anxiety disorder. So what are the features? The basic features. What is the patient will be having this generalized anxiety disorders? They are usually associated with the irritability. Okay, irritability, and frequently in the social situations. Frequently in the social situations. So the patients will be having the anxiety, along with that restlessness, and significantly this is going to disturb their sleep and lifestyle. So this is the most common. Overall, the most common is the generalized anxiety disorder. So for these patients, we can give the treatment. Okay, this is more than or equal to 6 months. For this patient, we can go for the SSRIs. SSRI can be given as a treatment for this patient. And if ever it is not done, then we can go for the CBT. And also relaxation technique such as Jacobson's progressive muscle relaxation can be also given for this patient. Next, coming back to the another disorder, that is a panic disorder. First, we'll know about the panic attack, then the panic disorder. Okay, so panic attack, the patient is actually having around 15 minutes. The patient is having severe attack, such as the patient can have sweating. Okay, patient will be having the palpitations, heart rate is raised, patient is having feeling like something is going to be going to death him. Okay, it is attacking him. So which we call as a impending doom of death. After 15 minutes, they don't have anything else. That is what the panic attack. But the panic disorder is the patient is having these symptoms, this having the intense anxiety, which is associated with the agoraphobia. What is mean by the agoraphobia? The public places or the closed spaces or any other situation, the patient is having the intense anxiety with any of the symptoms which is more than equal to 6 months, that is considered as a panic disorder. That is considered as a panic disorders that you have to remember. Agoraphobia, if we have to define this agoraphobia, the patient who is suffering more than or equal to two situations, let's say public place and let's say in the closer space, the patient is having the fear that is more than 1 month, that is having the more than 1 month. Suddenly the patient is in the lift, suddenly patient is in the crowd, patient is in the public place, patient is in the shopping mall, they will be having the sudden fear, that is agoraphobia that we consider. That is the one point that you have to remember. Next, coming to the some of the other disorders that you have to take note. What are those? That is the grief. Okay, these are the grief disorders. So grief disorders, how can you remember these grief disorders? We have acute stress reaction, we have acute stress reaction, and also we have the acute stress disorder, adjustment syndrome, adjustment disorder, and patient PTSD. PTSD. So what are these? Let's see one by one the definition. Acute stress disorder is less than 48 to 72 hours only. Okay, acute stress disorder, it is not a reaction, it is a disorder. This is less than equal to 1 month. Adjustment disorder less than 6 months, and this is more than or equal to 1 month. PTSD. So in the acute stress reaction, the patient will be having the shock, or patient is having like a dream, something is just happened, that is a reaction. And here the patient will be having the arousal, okay, emotional arousal that is present here, and patient will be occupied by the stress only. In that 1 month, the patient will be having occupied by the stress. And here the patient can be having the depression like symptoms, okay, depression like symptoms. And also patient may have the behavioral problems may be seen here. So this is what the adjustment syndrome. And here there is a significant event that is present before the PTSD. There is a significant event which is followed by the nightmares, flashbacks, and complete the patient will be social withdrawal. The patient will be from the social withdrawal, that is seen with the PTSD. So this is how you are going to differentiate between the different kinds of the condition. And grief reactions, stages of the grief reaction is also asked once. So let's remember grief reaction with the friends. So grief reaction is found by the, you all might have know, this is the Ross character, right? So scientist who has given the uh, grief reaction is also, his name is the Kubler-Ross. He is given the Kubler-Ross. How can you remember? So based on the Ross character, so Ross is always denying the fact. He will be denying the fact, and he is always anger. He is always anger comparing to the others, and after some point he will be bargaining his friends. He will be bargaining his friends, and due to his ongoing life, like with the Rachel breakup or any other things, he will be having the depression, and ultimately he will accept all this. So this is what the Kubler-Ross and Ross character and also the symptoms that is associated. Next, this is a Chandler. So just the Chandler, we have the many diseases with the Chandler. So we have the Chandler disease. So Chandler disease is avascular necrosis of the lunate bone. So this is not related to the psychiatry, but this question is asked. Next we have the Chandler index. Chandler index we use for the X, okay, X of the parasite count that we are going to use. And we also have the Chandler syndrome. This is eye defect which is acquired blindness can cause. So these are the different name with the Chandler name. Chandler syndrome, eye defect, and Chandler disease, avascular necrosis of the lunate carpal bone. Chandler index is about the egg index of the parasite. So this is what you can remember with the friends references. Okay, that's how just I remembered and I shared with you guys. Next, PTSD is also done. So this is the anxiety, general anxiety disorders that you have to remember. Next, coming back to the how we are going to differentiate with the OCDs. Okay, so here we have the personality disorders also. So I will be writing here about the OCDs, types of the OCDs. So OCD, obsessive compulsive disorder. If we have to describe the obsession, the obsession is a thought. Okay, obsession is a thought. How the patient will be having this thought? Intrusive. The patient will be having the intrusive and repetitive thought. And compulsion. Compulsion is the patient is performing that act. Okay, so the patient is perform that thought. Okay, that will be thought which is disabling the patients to do any other work, and it is also repetitive. And remember that OCD is ego dystonic. These are ego dystonic because we have ego syntonic also, that is different. So this is the ego dystonic. Then we have many other disorders. For example, hypochondrosis. So this question is asked in one of the Fmge examination. What is a hypochondrosis? Next, hoarding disorder. Hoarding disorder is present, and also patient who is having the body dysmorphic disorder. Body dysmorphic disorder. Then who is suffering from the trichotillomania? You might have heard trichotillomania. So what are these different diseases? So for example, hypochondrosis. This is associated with the illness. So the patient is actually normal. The patient is normal only. There is no illness, but the patient is having more than 6 months. The patient will be occupied about the illness. So he might be thinking he have different types of the illnesses or developing the illness. The patient will be thinking that is a hypochondrosis. Hoarding disorder is the patient is saving. Okay, so the patient is saving invaluable things in his life. Invaluable things in life which doesn't have any value. That is the hoarding disorder. For example, I have the childhood socks. I don't need it because it smells bad, but still this hoarding disorder patient will be saving that. That is what the hoarding disorder. Body dysmorphic disorder. Even though patient is having the good looks, patient is having the good smile also, the patient is thinking that Array, I might have something bad in my face, something wrong with my nose, something wrong with my lips, something wrong with my moustache. So the patient is preoccupied. So he is preoccupied with his body shape. Preoccupied with his body shape. That is the one thing. And trichotillomania. Trichotillomania means hair pulling. Okay, just simply the patient will be hair pulling, and after that they will eat. This is known as a trichophagia. This is known as a trichophagia. Once they enter, that will form the bezoar, that is known as a trichobezoar, and it can cause a surgical complication because we have to open and treat that patient. So this is a trichotillomania. Next, what is the treatment? So basic treatment for this patient is the TCA, but it is having the toxicity. So we will be using the low dose, that is with the low side effects, that is a clomipramine. The drug name is the clomipramine. This drug can be given for this patient. That is the one thing that we can use. Let's continue with the personality disorders. Let's continue with the personality disorders. We have the three clusters, guys. One is the odd, eccentric, and the patient is having the odd, eccentric type of the personality disorder. And the second one is the dramatic, unpredictable, and third one is the anxious and the fearful patients. So we will be seeing what are these patients is suffering. Let's say the patient with the cluster A symptoms, they have the different three types. One is the paranoid and schizoid and the schizotypal. What is mean by the paranoid? So the patient will be having the always suspicious. So the patient is always suspicious. Whatever you do, he will be suspicious. So the character is typically suspicious patient. Next, schizoid patient. Schizoid patient is a cold person. So this patient is like a cold. He doesn't have any emotions, any feelings, any empathy, like that. All this will be seen with the schizoid patients. Next, schizotypal. Schizotypal patient, it can progress to the schizophrenia. Can progress to the schizophrenia. And schizotypal is also mostly combination of the cold behavior, odd behavior. There will be having some problem in the life, that will be seen with the schizotypal. Next, antisocial. Antisocial is seen with the adult patient. Adult patient, this will be having the history of the crime, doing some problems with the society and complaining about him, and he is doing some rule breaking things, that is seen with the antisocial person. And the borderline patient, these persons are more of like a, so the patient will be having different kinds of the mentality. Patient is borderline, which will be associated with the suicide. Only suicide risk that is present in personality disorders is the borderline disorder. And histrionic disorder, there will do anything for attention. There will do anything for attention. Narcissistic person, you may have heard about the Hitler, right? Hitler is one of the narcissistic. They feel that they are grand among every person. They are grand about every person. Avoidant person is like an isolated person. Okay, he is avoided from the society, family, friends. Dependent person, they are dependent on others. Okay, for example, girlfriend, she's always dependent, or else boyfriend who is always dependent, they can't do their own works. That is what the dependent. And the obsessive compulsive disorder, which is also known as anachronistic disorder, and this is a type of ego syntonic. This is a type of ego syntonic. Same obsession compulsion is seen, but it is ego syntonic. So these are the three different types of the clusters and three different types of their disorders. Some points that you have to remember: which is going to have the highest suicidal is going to be associated with the borderline patients. And treatment for this patient is the dialectical behavioral therapy. They will be having multiple relationship statuses, multiple family history, and they will be always occupied with some work and with uh, the some type of lies. Everything will be seen in the borderline patients, and the treatment that is asked, that is a dialectical behavioral therapy. Next, coming to the suicide. If you have to discuss about the suicide, the most common form in the India they use is the hanging. Hanging is the most common type. Then who is more prone? Males are more prone. Unemployed, okay, unemployed, and without family support, and unfortunately this is seen with the educated people only. That is also most commonly seen with the educated and mature people, because of their personal problems. And suicide is not a crime in India, that is recently has updated with a new law. But we have parasuicide. Parasuicide is seen with the females more common, and this is just act only. Okay, they will try to die but they don't die. That is what parasuicide. Okay, they attempt to die but they don't die. That is what parasuicide. Next, we also have paradoxical suicide. Paradoxical suicide is, for example, I started patient with the SSRIs. Okay, and after starting the SSRIs, the patient mood is elevated. In this mood, the mood is fluctuating, so there is a high risk of suicide. High risk of the suicide. So can I continue the drugs? Yes, you can continue the drugs, but decrease the dosage, low doses, and you have to monitor this patient. That is what paradoxical suicide. Next, coming back to the child psychiatry. In the child psychiatry, there are the different questions can be asked, and one among them is the intellectual disability. So whoever the patient is having the intellectual disability, we have to do the IQ staging for this patient, right? Before this is known as a mental disorder, mental retardation. Now it is known as a intellectual disability. How we are going to calculate the IQ, whether us or whether the intellectual disability patient, how can we calculate? We use the patient mental age and also what is the patient chronological age into 100. So we are going to calculate with this. What are the types? Mild is around 50 and moderate is around 35, okay, and severe is around 20 and profound, which is irreversible, this is around 20 per 20 IQ. Okay, this is about the IQ. And how much is the disability? How much is the disability? This is the 100% disability, this is 50% disability, this is the 80% disability and 60% of the disability. So we are going to differentiate between the what are the types. Next, most common causes. Most common causes will be Down syndrome, followed by the Fragile X syndrome, and other all genetic disorders will be associated with the condition. And coming back to the other genetic disorders we also described, acquired. Can be acquired disorders can be seen in these patients who is the mental disorder. Yes, acquired conditions is also present in these patients. That acquired conditions can be trauma. Okay, trauma can be also associated with the mental retardation in the patients. Next, we'll discuss the some of the important other disorders we will be discussing. First and foremost is the ADHD. Okay, ADHD is the attention deficient disorder, attention deficient hyperactivity disorder. So these patients will be having attention is not present for this patient, and patient is hyperactive, and patient is impulsive. Okay, so these symptoms is present in this patient. And how we are going to diagnose? At least the patient should be having two settings, for example school and home, and more than 6 months, and patient should be more than 12 years. So then only we consider this patient is suffering from the ADHD, right? First thing. Then what is the drug of the choice that is given for this patient? So ADHD patients, we are going to give first stimulant drugs has to be given. That drug is the methylphenidate. This question is also asked. Methylphenidate is given for which patients? If the methylphenidate, this stimulant is not working, then we can go for the atomoxetine. If ever the alpha blockers is given, then we have to give the clonidine for this patient. Clonidine can be also given for this patient, right? Next, moving on to the another condition, that is the Asperger syndrome. What is the Asperger syndrome? So Asperger syndrome patients, they are having specific learning defect, specific learning disability, but the patient IQ is normal. Okay, Asperger syndrome, the patient IQ is normal. It could be writing, it could be maths problem, it could be science problem, or the patient is unable to play. That is known as a Asperger syndrome. Next, we have the autism syndrome, which is also known as a savant syndrome. Okay, autism syndrome or the savant syndrome. What happens here? Here also the patient IQ is normal, but socially the patient cannot do eye to eye contact, or the patient is having the problem with talking, so the language problems is abnormal with this patient. That is what the autism or the savant syndrome. Okay, this is the one of the other syndromes. Next, moving on to the another condition that we are going to look here. So this is the patient who is suffering from the Rett syndrome. So what is the Rett syndrome? Recently in the INICT also Rett syndrome question is asked. Rett syndrome is a genetic disorder, especially this is known as a X-linked dominant type. This is the X-linked dominant, and it will include the MECP2 gene is involved in this patient. Rarely this is seen in the males, most of the times it is in the females. So the patient is having the normal growth. At some point the patient growth is decreased, not just a growth is restricted, and also the patient brain growth is shrinked. So this will result as a patient with a microcephaly. So the brain defect is seen. So the patient is also having the disorders with the movements. Okay, so movements, disorders is also present in this patient. That is what Rett syndrome in this patient. And the patient IQ is completely distorted. And the treatment that we can give for this patient is the trofinetide. Trofinetide, this is IGF-1 analog that is given for the trofinetide as a treatment for this patient. Okay, that is the one thing that you have to remember. Next, we also have the stages, right? You have to remember what are the different types of the stages. For example, oral stage is between the 0 to 1.5 years. Anal stage, this is around 1.5 to 3 years age. We have the phallic stage, this is 3 to 5 years. And we have the genital stage, this is around more than 12 years. If ever anal defect is seen, OCD people. If ever the phallic stage is different, there will be having the histrionic personality disorder. That is the things that you have to remember. Next, I will be differentiating between the three important disorders. Okay, three important disorders. We have the opposition defiant disorder, conduct disorder, and antisocial disorder. Antisocial, this is a personality disorder, right? Let's see the differences. So opposition present disorder is less than 10 years. This is more than 10 years. And this is more than 18 years. So this patient will be having the temper tantrums. Okay, severe temper tantrums is seen in this patient, and patient will be doing always more and more zid karta hai a patient. Okay, the patient will be having very much, what we can say, the patient will be having the temper tantrums and also cry always. Okay, these are the different, the if you don't tell the patient please don't do that, he will be doing that is what. But can this patient do the antisocial? For example, is the patient going to crimes? So these patients, crimes is not possible because less than 10 years this patient cannot do the crimes. So here this patient is also having the temper. Okay, very serious, the patient is doing the social activities. Okay, it can damage and sometimes even crimes, beating the other people with a bat, beating the other glass car, damaging something. Okay, so damages all will be done by this patient's conduct disorder. So same as the adults also, he will be doing the damages. Okay, breaking rules, all this will be seen in the antisocial. Depends on the age, you have to differentiate which disorder the examiner is asking us. Mostly on the examiner will be asking us on the what are the types only, manage the patient will examiner will be asking us. Next, the most important one guys, this is a substance abuse disorder. So substance abuse disorders, if you have to discuss, you have to discuss about the what are the toxications and what are the withdrawal symptoms. So first one will be starting with the barbiturates. So these are the drugs of the barbiturates. So barbiturates examples is phenobarbital, thiopentol. These are the examples. What are they do? So they do increase the duration of the GABA A. So GABA A will be increased in the barbiturates patients. If ever the patient is taken the excess, so what happens to the toxicity of the body? So the toxicity which will be increasing with the BP, the blood pressure is increased in this patient, and more than that, the patient respiratory distress is seen. Okay, so the patient will be having the respiratory distress. This respiratory distress is not due to the normally into the lungs. It is going to cause a respiratory depression in the inside the brain. So that is the prominent symptoms that is going to seen in this patient. One thing, and if ever you stop the drug, that means withdrawal. This withdrawal can cause the delirium. Okay, drug induced delirium that is only seen with the barbiturates. And cardiovascular collapse is seen in this patient. So this is the toxicity if you take excess, and if you suddenly stop, withdrawal symptoms. Next, moving on to the benzodiazepines. This is the benzodiazepines. So benzodiazepines, what is the mechanism for this? This will increase the GABA A, same as the above, but it has the frequency. So the frequency of the GABA A intake will be increased by the benzodiazepine. Just remember DAR and BAR. barbiturates, dar, that is the rhyming words, and here free and ben, free and ben, that is what the benzodiazepines mechanism. And if ever you take the toxic dosages of the benzodiazepines, what happens? So the patient can have the ataxia, and same it is also going to present with the BP, and also the patient will be having the respiratory depression because both are acting at the same place only. So it will be also causing the respiratory distress. Only difference that you find is the ataxia that is present in this patient. Next, you have started the patient with the withdrawal. So withdrawal symptoms, the patient can have the seizures. We are actually using this drug for the seizures, but this patient can have the seizures, depression, and sleep disturbances. That is for the withdrawal symptoms. But what is the antidote? So antidote for this patient is the sodium bicarbonate. Sodium bicarbonate is given for this patient. Here antidote is flumazenil. Flumazenil is given for this patient. Next, coming to the amphetamines. This is the amphetamines. So amphetamines drug that is going to do the increased norepinephrine, increased serotonin, and increased dopa levels. So all this will be high is going to give, right? So the patient will be having the euphoria. If it is in the excess, the patient will be having the euphoria, and the patient is very much alert. The patient will be having the alertness around him, and patient will be wakefulness increased. All this will be seen with these drugs. And pupil dilated pupils will be also seen. And sometimes the patient can have the excoriations on the skin, so patient only scratching that can cause the excoriations, that is also seen in this patient. Next, if ever the patient is stopped the drugs, the euphoria is decreased, patient will be having the sweating and flu like symptoms. Okay, flu like symptoms will be seen in this patient, and along with that patient will be having the tactile stimulation, tactile hallucinations. Next, what is the drug that we given for this patient to treat this? Lorazepam. Benzodiazepines is given for this patient, that is lorazepam is given for this patients. Next, coming to the plant based, that you have to take note. What are the plant based drugs here? Drugs you can see here, this is opioids, right? This is the opioids, this is the coca plant, right? This is the cocaine, this is the other drugs, that is cannabis. So let's see what are the types of the intoxications and the withdrawal symptoms that these patients will be suffering from. Okay, intoxication, sudden symptoms, and withdrawal. Every drug will be having these symptoms, you just have to identify them. Let's see one by one. So first, opioids. Whenever the patient is taken the opioids, you have to remember the three points. One is pinpoint pupils. The patient will be having the pinpoint pupils. Respiratory distress. Patient is having the respiratory distress. And along with that, the patient will be having the hypothermia. Temperature is decreased in this patient and respiratory rate is decreased. The patient sometimes can come in the coma also. That is what intoxication. Pinpoint pupils, no secretions, respiratory rate is decreased, temperature is decreased, and the patient is having the respiratory depression, that is going to present as an intoxication. If ever the patient can kill the patient, death can happen, that is most common with the opioids only. The one point that you have to take note. And for the withdrawal, what are the symptoms? Opposite to that, the patient will be having the mydriasis, means dilatation, and the patient will be having the diarrhea. Okay, patient will be having the sweating, patient will be having the salivation, also lacrimation. So this is completely opposite, right? So the patient is having all the secretions is increased. That is the withdrawal symptoms that we are going to see. Coming back to the cocaine, what are the cocaine symptoms that you are going to see? Dilatation of eyes. Opposite to that, dilatation of the eyes, and the patient will be having the hallucinations, hallucinations, and chest pain. This is known as a angina. So the patient will be having the angina also seen in this patient. And if ever the patient is taking chronic, if ever the patient is taking the chronic, there is a perforation of the nasal septum. Because this is a vasoconstrictor gas, so this can increase the BP in the patients and it can cause the perforation to nasal septum. So epistaxis can be also seen in this patient. That is what intoxication. Next, withdrawal. The patient is hungry. Patient is does not have the sleep disturbances was seen. Patient will be depressed and also run amok, that is associated with this condition only. The patient is also having the amotivation. Okay, no motivation is seen in this patient. That is what cocaine that will be associated. Next, cannabis is actually a good because it can be used as a treatment, but if it is misused, that is going to cause the intoxication. Cannabis have the two types. One is the tetrahydrocannabinol. Okay, this is going to cause the side effects, but we also have the cannabinol. This is used for the treatment of the diseases. Okay, so for the medical purposes, this is the best drug that is going to treat for the depression, that can treat the seizure disorders and also many other glaucoma and other conditions. Let's see what is the symptoms that the patient can have. So the patient will be having the appetite, increased appetite, so the patient want to eat more, and patient can have the anxiety issues. Delusions will be seen in this patient. Okay, dry mouth and also mydriasis, dilatation of eyes, that will be seen in this patient. Withdrawal symptoms. The patient will be having the depression. Okay, insomnia, sleep disturbances will be seen the patient, and also the patient cannot think properly. So cognition is disturbed. Cognition is disturbed. So this is what's seen in the withdrawal. Next, how we are going to treat then of all these patients, how we are going to treat. So for this patient, we'll use the other pen. So for this patient, I'm going to give the IV naloxone. And for the withdrawal, we can go for the methadone as a treatment of the choice for this patient. And here we can give the diazepam. This is given as a diazepam, and here we are going to use the commonly, if ever the patient is having the condition like this withdrawal, we can still use for the benzodiazepines only. And cannabis is supportive treatment. Whatever the patient is having, you have to withdraw them and you can go for the IV fluids as soon as possible for those patients. Next, we have the alcohol. So how the alcohol is going to work in the body? So simply alcohol is increase the GABA A and decrease the glutamate. So the main mechanism of the action for the alcohol is it will increase the GABA, decrease the glutamate. Cigarettes, this is going to increase the nicotine in the central nervous system. It is going to increase the nicotine levels. That is what the patients who are associated with the nicotine will be seen. And what is the symptoms that is going to associated? You all know that the patients who are taking the alcohol, that the patient might be having the symptoms, what disorganized speech and coordination is disturbed, the patient talking will be disturbed. That is what in the intoxication. And what about the withdrawal symptoms are very important for us. Okay, withdrawal symptoms are very important. Let's see one by one withdrawal symptoms. So withdrawal symptoms will follow the timeline. Okay, withdrawal symptoms will be follow the timeline. So let's say that the patient is stopped drinking at 6 hours. After the 6 hours, 12 hours is happened. He is still not drinking. 24 hours, still not drinking. 48 hours. Great progress. The patient is not drinking. But our body does not works like that. So this body started to hit the patient like he has to die. That is how the patient will be having severe symptoms. So at the 6 hours, the patient heart rate will be racing. So the patient is having the anxiety and sweating, palpitations. This will be seen in this patient. And 12 hours, the patient started to think about the auditory hallucinations. Okay, the patient will be having the auditory hallucinations. Still the patient is conscious. He is having just hallucinations. Next, at 24 hours, so the first GTCS, the patient will be having the seizure. okay, at 24 hours, and after the 48 hours the patient will be having altered sensorium. Okay, patients sometimes even go into the coma also. So this is stage we are going to see the delirium tremens. Delirium tremens, one of the most severe condition that you are going to see in this patient. So immediately what you can give, you can start the patient on the lorazepam. Okay, you can start the patient on the lorazepam. That is what the treatment of the choice for the withdrawal symptoms of the this. For example, let's say the patient is having the alcohol history. He can develop the two lesions. One is the Wernicke's and other one is the Korokov syndrome. So what is these two syndromes? Wernicke's syndrome, which will be associated with the global confusion. Patient is having the global confusion, also ataxia and ophthalmoplegia that is seen in this patient. And here the patient is having the anterograde amnesia and also confabulation and personal identity is lost in this patient. Where is the lesions? So the lesions that is present in the Wernicke's patients, it is present in the mammillary bodies. This is present in the mammillary bodies, and here in the Korokov syndrome, it is present in the thalamus. So it is present in the thalamus, especially anterior thalamus. Right? So this is what the Korokov syndrome and the Wernicke's syndrome. How we are going to treat these patients? So these both conditions, first and foremost, you have to give this patient thymine. Okay, thymine is the first thing you have to admit. This is first should be given, followed by the glucose. So this is how you are going to treat the thymine. Next, we can go for the other drugs also. What are these other drugs? Some drugs are like irritants. So these drugs can be treated as a irritants, which we can give for this patient, and some we can go for the patients with the deterrents. So there are the two types. One is the anti-craving drugs, and other one is the deterrent drugs. Anti-craving drugs are such as, so what are the anti-craving drugs? Anti-craving drugs we have acamprosate and topiramate and baclofen. So this is the anti-craving. And deterrent drugs. Deterrent drugs we have disulfiram. It is an irreversible drug. Once it is attached, it is hardly we can remove. Where it is irreversible at the aldehyde dehydrogenase. So aldehyde is not going to convert, so that can trigger the deterrent effects in these patients. So drugs like metronidazole and also cephalosporins are contraindicated because it can cause the severe side effects in the patient. So these are the two drugs that we are going to use, anti-craving and the deterrent agents. Next, coming back to the nicotine agents. So in the nicotine, we can stop the nicotine. So because the nicotine patients, if ever the patient is taking, there will be highly associated with the stresslessness, pastlessness, all this will be seen. But the patient, if they are stopped, they are going to have the anxiety, irritability, stress, sleep disturbances, patient lifestyle changes, all this will be seen. So how can we start the nicotine? So we can start the nicotine with the drugs. Okay, we have the drugs, anti-craving drugs we have. One is buspreopon, and next we also have the cycline. So these two drugs we can use. So bupreopon, this is going to increase the norepinephrine and increase the dopamine levels, and the cycline is the best agent. Let's say this is going to act on the alpha b4 and b2 agonist. Okay, this is most effective. The patient will be having the, never they are going to take the nicotine if they are used as per the timeline. Next, other one we have the nicotine replacement therapy. So what is this nicotine replacement therapy? So Here the picture you can see, you can use the nicotine pouches, nicotine gums, nicotine lozenges or the nicotine pouches. But the rule is that you should not take the hot liquids or the beverages at least 15 minutes prior to the drugs. Contraindicated. You should not take the hot liquids, hot beverages at least 15 minutes before this, because this is going to work on the buccal mucosa. This is going to act on the buccal mucosa mechanism of action, and if you take at this point, it is not going to work. So that is why it should not be taken, and it can cause sometimes irritation. Irritation is seen, but it is safest only. That is no problem. So these are the nicotine replacement therapy. Next, coming to the sleep cycle and the disorders. So we will be discussing of the sleep cycle disorders and some of the other important points that you have to remember. Okay. Other than that, we will be finishing of this chapter, guys. Next, let's see. So sleep. So sleep is mostly due to which one? It is due to melatonin and adenosine, galanin, and also GABA. Right, these are the important effectors that is going to cause the sleep for us, and also sometimes magnesium plays the role, so that's why magnesium supplements can help you to sleep also. Next, coming to the sleep has the different stages. It is divided as a non-REM stages and the REM stages. Non-REM stages, we have the N1, N2 and the N3. So this is around 45 minutes. Okay, next we have the REM stage. This is only REM 1 stage. Okay, this is around 25 minutes. Okay, around 70-75 minutes we will be having the sleep episode, and it will be recycling whole night. That is how we are going to sleep. So how we are going to have, we have the different types of the waves you can see here. Okay, so when you are awake, this is going to presented as a beta waves. These are the beta waves. Okay, after the sleep, the stage 1 will be the alpha, stage 2 is the theta, stage 3 is the delta, and coming back to the REM stage, it is again beta waves that is going to have. So sometimes this question can be asked in the examination with the graphical representation also, right? With the graphical representation also it can be asked. Next, coming back to the discussion. So how the sleep cycles are divided. So as we said, the patient is awake. So the patient is awake. So in the stage of the awake, so the patient is having the beta waves. Beta waves is seen. When they are asleep, when they are going to sleep, this is going to replace by the alpha waves. Alpha waves. Even when you are in the meditation also, alpha waves are generated in our brain. Alpha waves, where it is coming? It is coming from the occipital region. Beta waves is coming from the frontotemporal. Beta waves is coming from the frontotemporal, right? Next, once you are asleep, you are going to enter the N1 stage. You are going to enter into the N1 stage, and N1 stage is short stage. It is a very much short stage, and in this short stage, you are going to have the theta waves. Okay, you are going to have the theta waves, and also hypnic jerks. You might have no hypnic jerks. Suddenly you will feel the jerk. That is in the N1 stage, followed by the N2 stage, and N2 stage is the broad. Almost 45% of our sleep is in the N2 stage, and here you are going to see the K complex, which is associated with the high voltage, K complex, high voltage, and the sleep spindle. This is the short voltage. So let's see what are these. Here you can see. So this is the wave that is seen in the K complex and sleep spindle. K complex, split spindle. K complex, sleep spindle. So this is what we have just discussed. This is the K complex and the sleep spindles that is present in the N2. Followed by in the N3, this is only the few percent of the sleep, like a disturbed sleep also sometimes. This is the delta waves. And here we are going to have the night terrors, which you don't even remember this night terrors. Next, followed by the REM stage. Okay, followed by the REM stage. In the REM stage, we are going to have the sawtooth and paradoxical sleep. This is the paradoxical sleep. And also we are going to have the nocturnal erections in this stage only. Nocturnal erections, nightmares is seen, and PGO spikes is seen in the REM stage only. And where we bite the teeth, so biting the teeth, bruxism is seen in the N2 stage. Bruxism is seen in the N2 stage. So these are the different types of the stages that can be asked in the examination. Okay, next, coming back to the only the things that you have to remember. Insomnia. So patient who is suffering from the insomnia, how you are going to diagnose? So more than 3 nights per week, and more than 3 months, if ever the patient is unable to sleep despite of his trying, that is considered as an insomnia. For this patient we can give the melatonin agonist. Okay, melatonin supplements or the melatonin agonist can be given. And also some of the drugs, the Z category drugs, these drugs are the zolpidem, can be also given for this patient. This will be increasing the GABA A levels in the patients. Next, narcolepsy. So narcolepsy is opposite to this patient. So the patient is having irresistible to sleep. So patient want to sleep but unable to sleep in the night, but excess of sleep in the morning. So that is what's seen in this patient. Here orexin in the hypothalamus, that is decreased. Orexin is decreased. Cataplexy, not lexy, this is cataplexy. So cataplexy, suddenly the patient is having the laughter, he will unconscious. Suddenly patient is having the surprise, he will be unconscious. Not unconscious, they actually going into the sleep. So that is known as a emotional stimuli. That is cataplexy is seen in this patient. And what is the treatment that we can give for this patient? The treatment and drug of the choice for this patient is the modafinil. Okay, modafinil can be given for this patient. This is the narcolepsy and also the sleep cycle that you have to remember. Next, moving on to the food disorders. First, we will be discussing about the binge eating disorders, which is most common overall. Binge eating disorders is the most common overall. And next, anorexia disorder and bulimia nervosa. How can you differentiate first point among all these? So the first point that you have to differentiate is from the BMI. So BMI in these patients will be high, severe obese also. So here the BMI will be low, and these patients the BMI is normal. One difference. Next, the patient here binge eating, there will be eat a lot and they will eat in the isolated settings. They can do the purging also. Most of the times purging may present, purging may not absent. And the guilty after eating. So the patient is having the guilty after eating. So this is what bulimia nervosa that is seen in this patient. Next, binge eating disorders. Next, anorexia patients, completely BMI is decreased. Here you can see this is the patient of the anorexia nervosa. So they have the excess of the fear of the weight gain. So they don't eat at all. They can also do the purging. If they ate, they will do the purging, or they can completely restrictive. So that's why this patient can have the arrhythmias. Patient can have the electrolyte disturbances. Okay, electrolyte disturbances will be seen in this patient, and also menstrual changes will be seen in this patient. Okay, menstrual changes also seen. That is what anorexia nervosa, and also associated with the suicide pattern. Next, bulimia nervosa. These patients who is suffering from the bulimia nervosa, their BMI is normal. Either they will be having the purging, after immediately eating, they will do the purging, and again they will eat, binge eating and plus purging, or they use the laxatives. Okay, laxatives abuse, that is also seen with the bulimia nervosa. This is the treatment. So drug of the choice for these patients of the binge eating disorders is supportive treatment. Okay, supportive treatment can be given for this patient. Drug of the choice for the anorexia nervosa patients. For the anorexia nervosa patients, what we can do in these patients is we can go for the SSRIs, as the suicide risk is present. And in the patients of the bulimia nervosa, for these patients we have the specific drug. The specific drug we are going to follow in this condition is the amphetamines. So amphetamines, if you can give this drug for this patient, these amphetamines drugs can be decrease the condition. So here, if you want to give, the drug of the choice is the amphetamine. One of the type is the left-dex amphetamine. And for the patients of the anorexia nervosa, the drug of the choice is the antipsychotics, olanzapine and also fluoxetine. Fluoxetine is given for this patient. And here also the drug of the choice is fluoxetine is given. Okay, these are the eating disorders directly can be asked in the examination, right? Next, coming to the miscellaneous topics. If we want to discuss the miscellaneous topics, the questionnaires, SCOFF questionnaire. So where we are going to use the SCOFF questionnaire. SCOFF questionnaire is used for the eating disorders. SCOFF questionnaire is used for the eating disorders. Next, classical conditioning. So classical conditioning, where you are going to see. So classical condition was given by the Pavlov. So whenever suddenly the association, for example, you have bell with the food. Okay, whenever you make the bell sound, the food, this is going to get the dog stimulus. Okay, this is going to get the dog stimulus, and after you are ringing the bell, the dog will come here for the food. So this is a involuntary type. Involuntary, right? So this is the involuntary stimulus that is seen with the patient or the human beings. Next, we have the operant. We have the operant conditioning. So operant condition is given by the Skinner. Operant condition is given by the Skinner. This is associated with the behavior plus consequence. How? Let's see. For example, you have active and voluntarily you are participating. Okay, in the voluntary, let's say you are participating in the quiz. I said that if you win this quiz, you will get the gift. So you are actually actively participating for this gift. So you already know this and you are behaving according to consequences. That is what the type. Next, transference. So what is transference? Transference means the patient is having positive or the negative feelings towards the doctor. Okay, that is what the transference. Next, we also have the counter transference. Again, this counter transference also same. The doctor is having the positive or the negative feelings towards the patient. So this is the transference and counter transference. Next, we have the id. So we add the id, ego, and also super ego. So id means the patient is having the pleasure. Okay, this is the pleasure, and this is the reality. Ego is the reality, and this is the morality. Id, ego, and super ego, that you have to take points. Next, we have also the classification MMSE. MMSE is consisting of the 30 points used for the delirium patients. Okay, delirium patients, I am going to use the MMSE that can be used for this patient. Mental retardation patients. For the mental retardation, what we are going to use in India, we had the Bennett-Kamat test. Bennett-Kamat test. This is used for the mental retardation or the intellectual disability patients that we can use this. That is a one point that you have to remember. Next, we have the mature defenses. Okay, mature defense mechanism. Mature defense mechanism is work by the ego. Mature defense mechanism is works by the ego. That is the one point. And what is the most common that every person will be having? That is the repression. Repression is the mature defense most commonly present in every one of us. That is a mature defense. Next, projectile test. We have the projective test. So in the projective test, we have the thematic test. Thematic test. This thematic test, there is an image and will tell the patient to write. or tell the patient to tell the story. That is what the thematic test, and this is to check the patient stimuli. This is to check the patient stimuli. Next, coming to the mental act, we have the mental act. This mental act is given 2017, and this will tell us we have to do some prohibitions of the patients, and also we give the patient right to have the advansive directive. Okay, even though the patient is intellectually disabled, we'll tell the patients, we can give the patients is a chance that they can have how to treat it and how to not treat it and who can help them to treat. That is all this will be given in this advansive directive, that is given the choice for these patients, right? These are the important points that you have to remember, and just we have discussed, right? So Kubler-Ross, this is the grief, this is the grief stages, and we have the Chandler syndrome, Chandler disease, and next here Monica is most commonly associated with the OCD. So this is just for the fun, guys. If you feel any problem or the stress, you can watch this series. It will going to give you the some of the good vibes also. So please do read all these important topics and practice before the examination. Especially this first page is very important. All the antipsychotics, antidepressants is has been asked, and all these topics are very important. So please do watch the remaining videos also, guys. Those who are new to this channel, please do subscribe and share with your friends. And until then, see you guys in the next videos. Happy preparation.